Okay, well, I'm going to talk a little bit about the prevention of paraplegia. My main interest in this is obviously toracoabdominal aortic aneurysms, where the risk is much higher than for pure thoracic aneurysms. But it's a very variable risk, and you do see it with the conventional single lumen treatment of a thoracic aneurysm. I think the lessons you learn in one can be applied to the other. The first lesson you learn is that you're not dealing with your father's paraplegia. Surgery is quite different in terms of its effect on spinal perfusion than endovascular. The cross-clamping of the aorta, the hemodynamic disturbances can all contribute to a situation where the patient wakes up paraplegic. And the characteristic picture is of complete, immediate and permanent deficit. In endovascular repair, the patients tend not to wake up paraplegic. They tend to develop that relatively early as the type 2 endo leaks resolve. And very often the pattern of deficit is partial, and very often it is reversible. So what is the real problem? What is the etiology of paraplegia? And there were two competing theories. One, a sort of old-fashioned theory, says that the critical part of the aorta is the one that gives rise to a critical radicular branch to the anterior spinal artery, the artery of Adamkowitz, or the great radicular artery. Probably a more modern interpretation of the etiology is that paraplegia occurs when all of the inflows summated together are not adequate to meet the needs of the spine. And if you look at the two approaches, they suggest different treatments. The one that seems to be the more effective is to pay attention to overall flow and to physiologic methods to improve overall flow. And one of the reasons for this, if you look at a post-op CT scan very carefully, you can see that there are intercostal and lumbar arteries extending around and feeding the spine despite the presence of a working stent graft. These things are being fed by a network of tiny collaterals that run up and down the spine. And the more of these you have, the less likely you are to become paraplegic. So we have anatomic causes of paraplegia, loss of intercostals, loss of the internal iliac, loss of the subclavian. There are also non-anatomic. So if the patient's hypotensive, if the spinal fluid pressure is high, and then the metabolic consequences of ischemia that render all of these effects permanent. As I said, the event rate with a typical thoracic aortic aneurysm is relatively low, but the lessons you learn with toracoabdominal do apply. The other thing is that although lower extremity weakness is relatively common, paraplegia has become relatively rare. If you want to know about the risk factors, you have to study something with a high enough event rate, which for us means lower extremity weakness. Well, as I mentioned earlier, kind of an obvious cause is low blood pressure. If there isn't enough blood going in to the collateral system, there won't be enough blood coming out of it to feed the spine. And here you can see an observation from our early thoracoabdominal experience. So, and these are the conclusions that we've drawn. If you see hypotension, it's often associated with lower extremity weakness, and persistent hypotension is associated with paraplegia. Fixing that will fix the problem. The converse is not true. Hypotension in a patient who has lower extremity weakness will not help. You can't help the situation by driving the blood pressure up from 160 to 180 to 200. That's just not going to help you, especially if you have to use pressors to do it. If you can give a transfusion, increase the cardiac output, increase the blood pressure that way, that is more effective than pressor administration. Internal iliac arteries are very important collaterals. You must preserve them. Here I've just reiterated a few of our general observations, that people don't wake up from anesthesia paraplegic. They have a borderline perfusion that makes this reversible. Interestingly, many of them have back pain. I suspect they have ischemia of the paraspinous musculature as well as the spine itself. And prompt CSF drainage is the most effective method of intervention by far. if you get any recovery, you're usually going to get full recovery. By that I mean the patient, when they come back for their 1-month appointment, will be able to walk in to see you. Interestingly, we've observed collateral recruitment over a very short time course. This doesn't correlate necessarily with the increase in size of lumbar arteries. There's something else going on. We don't know what it is. If you look at this clinically, you can see that a patient who requires CSF drainage on post-op day 1 may not require CSF drainage on post-op day 3. Something happens during that period. That's not the lumbar hypertrophy that takes far longer. Animal experiments have tended to support this concept, looking at the effects of intercostal artery occlusion 1 hour and 72 hours after an initial insult. This has led to the concept of a staged repair, where you have these perfusion cuffs that continue to feed the aneurysm and feed some of the lumbars or intercostals while the others are left to thrombose. I'm not a big fan of this procedure, partly because I don't think that this phenomenon is the cause of the paraplegia. I think that embolism is a far more common cause. So our policy for a TAAA repair is we tend to hold antihypertensives to allow the patient to become a little bit hypertensive in a permissive fashion. We may consider staging the procedure, as you saw there with the cuffs. We tend not to do that. We try as much as possible to preserve all the collateral pathways, so we will do a carotid subclavian bypass, or we will treat an iliac artery aneurysm with open surgery to preserve a route of perfusion. We always drain the CSF. Initially at a relatively slow rate. If the patient becomes symptomatic, we will increase it and titrate it to symptoms or to headache. We take great pains to prevent hypotension or treat hypotension if it develops, and we allow the patient to reintroduce their antihypertensive medications over the first 1 to 3 months. If you look at our experience, in the 110 patients, the first 55, you'll see we had lower extremity weakness in 18% of the cases, but 7% of those became paraplegic. The rules that I was telling you about were things that evolved. We didn't know these things right away. In the last 55 cases, we've had 25% of patients who developed lower extremity weakness, but only 2% have become paraplegic. It's become quite a rare event, and usually due to embolism. What about thoracic aortic aneurysms? Well, the risk varies widely according to some of the things that I discussed, the extent of the aneurysm, the state of the collateral vessels. You can't sit around and say, okay, if we've got this high-risk patient, and if he needs CSF drainage, we'll do it, because by the time you do it, it's going to be too late. And really, if you think it's a high-risk case, if you're going below T8, you should make sure you preserve the left subclavian artery. So in conclusion, lower extremity weakness is common after thoracoabdominal aneurysm repair, but it's often treatable except in the case of embolism. As a result, paraplegia is rare, but of course it's a devastating permanent disability and it's preventable. So its causes need careful attention. Thank you.